anonymous participant has joined.
Hello, everyone, to your BC 2020 Week 2 live chat session. I am Instructor Howard, and what I have here is our list of tasks to be completed this week. Now, if you need a little more review on CPT coding as a whole, there is a CPT video tutorial that if you don't have access to it, I will post the link to that in the discussion area for course questions. This week we're working in chapters 18 and 19 of the step-by-step medical coding textbook. If you do have the 2012, then the same chapters are applicable in the 2011 step textbook and workbook. Review your chapter videos to focus or become familiar with coding for the Integumentary System, which is chapter 18, and the Musculoskeletal System, which is chapter 19. You have your self-test that you would complete before you do the actual assessments, so you can make sure that you have a good understanding of the topic. You have to complete your educational activities, which is basically completing workbooks and following through and downloading the answer keys that are saved inside of the course content under each chapter, under educational activities, so that you can compare your answers. And then you have 2 coding applications, well, basically a test for chapters 18 and 19, the general test, and then coding application. We have discussion, and we also have an assignment and your web-based training that you're going to be doing this week on the CMS website. The lecture is going to be focused on chapter 19 of the step-by-step textbook. Chapter 19 is dealing with the musculoskeletal system, and so what I'm going to do is just focus on that, talk about that today. What I also will do is post some anatomy videos for you to review the anatomy of both the integumentary system and the musculoskeletal system. One thing that helps you do coding is the ability to understand what you're coding and what you're reading, along with following instructions in the CPT manual for any additional notes that are inside of the sections. So, of course, both integumentary and the musculoskeletal systems were coded out of the surgery section. The code ranges for the musculoskeletal system are the 2s, and if you're using the edition of the CPT book, that information will begin on page 61 of the CPT manual. It gives a long overview of the terms, for instance, closed treatment, open treatment, and percutaneous, manipulation, excision, and incisions. So what I do is I'll just come out or cover the information that's based out of the step-by-step manual, but it's also giving us additional information of how to use the CPT manual to code for these sections. So you follow along with both your CPT and your step-by-step textbook. So the subsections that you're going to run across are divided based on anatomic site, for instance, forearm and wrist, and then the service, for instance, incision, excision, introduction of removal, repair, revision, fracture, dislocations, arthrodesis, and amputation. So the subsections, again, reflect the anatomical site. Within each anatomical site, the subheadings continue to reflect the procedures performed. Many musculoskeletal codes, such as those used for splinting, casting, and fracture repairs, are also used by primary care and family practice physicians. So it's important that you are aware that almost any type of provider that you will be billing for will possibly use codes out of this section. Also contains many notes, and it's very important to carefully review your notes as because the notes tell you how to use the information and will identify any new qualifying circumstances, conditions, and modifiers. These codes are mainly used by orthopedic surgeons, but once again, they can be used by a variety of physicians, so it doesn't matter. We have here the most types of codes that you across are like the fractures and the dislocation and the treatments under the general subheading, which is the very first section CPT at the bottom of page 62. And then like arthroscopic procedures, which are procedures that are done with a scope to view inside of the bone area or the joint area as the provider is rendering the service. Miscellaneous procedures that are not specific to any anatomical site, such as incisions of soft tissues and abscess, wound explorations, biopsies of the muscles and the bones, and casting and strapping. You know that any types of fractures can be, can cast or a strapping, or even strains and sprains. So here's things that you ask yourself when you're coding for fractures: the state of the fracture or the dislocation, and the type of treatment, whether it is open or closed. Once open treatment refers to a surgery that opens the skin to view the actual bone or organ that the provider is working on, and the closed treatment will basically be what I call an arthroscopic, so done through a scope. The general term would be endoscopic, but since we're dealing with the bones, the ligaments, then the term would be considered arthroscopic. So you have dilation, which is done like manual services that the provider would use his hands, and then you also have traction, if traction was used, and then, of course, what type. And the traction, if you don't know what that is an additional device that is used to help keep the bone or the repair at a steady angle. And then again was percutaneous fixation used. Percutaneous is used with pins and needles that is inserted into the bones or joints to keep the fracture that is being repaired closed or placed back together. Then another question was internal fixation applied. Make sure this is not included in the code description. Internal fixation, if that is used, then that may will possibly need change your code that you use to code for the service. Internal fixation, once again, are pins and wires, but that is used when the provider opens the skin, locate the bone, or expose the bone, and use pins and needles or rods to put the bone in place. Is placed on the body to keep the bone or the fracture in place and to be repaired. So they may not open the wound to do a percutaneous fixation. And they'll have what is an external fixation applied, and then did documentation support the skin closure, and what type of anesthesia was used, whether it was local or general, or what the block. On to your treatment, you have open, which is surgically open to view, or remotely open to place the nail across the fracture. Open with internal fixation, and that is the acronym ORIF. And some factors are coded by treatment, which may be open, closed, or percutaneous. So the way that these types of fractures differ are typically open and percutaneous treatments require surgical intervention, whereas closed treatments may sometimes be completed without taking the patient to a surgery suite. Closed treatment site is not exposed by surgical incision. Percutaneous is neither open or closed, which are used fixation devices such as pins, that are placed across the fracture site under the imaging guidance. Not to be confused with the type of fracture. Once again, you have various types of fractures, and those are shown figure 19-1 on page 575, and I'm trying to get my book in place. In terms, you have an open fracture where the bone penetrates the skin, so the bone is exposed. You have a closed fracture of which the bone does not penetrate the skin, but it is fractured. Person or the provider can see it under X-ray. And so you can see that there are different types listed here. For instance, you have your green stick fracture, which is like a small hairline fracture. You have a convoluted fracture, which is kind of like a compound, similar to a compound fracture, where multiple portions of the bone is fragmented. You have a compound fracture, which is also known as an open fracture, where the bones are fragmented, but it also penetrates the skin. You have a Colles fracture, which is like around the wrist. You have an oblique fracture, which is torn obliquely, diagonally. You have impacted fracture, which the bone crushes into another. You have spiral fracture, which looks like an oblique fracture, but the spiral is open. You have a transverse fracture, which is broken across, directly transverse across the middle. You have avulsion, which is a lift up of a portion of the bone. And then you have a simple, considered a closed fracture. So the word complicated. And complicated in the code descriptor may indicate excessive hemorrhage, infection, prolonged physician work, difficulty in reaching the site or depth of site. So there are some treatments that are simple, and you'll see that in the description, and there are some treatments that are complex. And so moving on page 576, it gives you some more description of the types of treatment, like closed treatment. But I will talk briefly about manipulation before I move on. Manipulation is attempted reduction, which is an attempt to maneuver the bone back into a proper alignment. The physician may bend, rotate, pull, or guide the bone back into position. So for the services that the provider render, and it's not, this slide here is not really talking about that. I just turned to page 576, and I'm talking about the information on that page before I move on to traction, because traction is listed on the next page. But I want to make sure you guys understand what manipulation is. So when there's different types of treatment that the provider renders, whether it's open or closed, sometimes you'll see in the description with manipulation or this service with or without manipulation. So that is a key and a clue for you, so that when you are looking for codes, you have to understand if manipulation was done, which is moving or forcing the bones back together with the hands, then, of course, that would change your code. Moving on to this slide, we have the word traction. And I talked about this a little bit earlier. And this is an application of a force to align the bone. And as you can see here, the patient is stabilized on a bed or a couch or, on a hospital bed, and this traction device is pulling the bone or using the force of gravity to align the bone and make it heal properly, that it does not mend abnormally. So the pulling force to bring the bone into alignment and hold it there is called fraction. So it's like with a closed repair, because it is the only option. In an open repair, the bones may be brought into alignment directly. For instance, manipulation may pull this bone back together. But with closed treatment, oftentimes what they'll use is a traction device to, use the force of gravity to allow the bone to join and mend back together. The skeletal traction device, use of force, for instance, distressing or traction force applied to internal device such as a wire, pin, or screw or clamp that is inserted into the bone. And as you can see on the bottom portion here, let me move this a little bit. There you will see the wire going into the and bringing the humerus back together, the ulna and the humerus and the radius. You know, they're there, and so the person has to hold their hand in this position for a long period of time in order for the mending to take place because of the pin that is inserted right here. So there are skeletal and skin. With skeletal traction, internal devices such as pins, screws, and wires are inserted directly into the bone through the skin. The protrude end attached to traction devices that use weights and pulls. And as you can see here, there's a weight there, there's a weight there, and then there's a pull here. Weights and pulleys to hold the bone into place. So the question that is posed is, does skeletal traction require an open procedure? The answer is no. The internal devices are inserted through the skin right here. And what they would use is some imaging guidance to help them place that particular wire or pin in the proper place. More information about skin traction is the application of force by means of adhesion to the skin. So when skin is used, devices are attached to strapping or tapes that are placed around the limbs. Force is applied by the means of adhesion to the skin. Adhesion is tape. So the question is posed, why is skin traction less stable than skeletal traction? The answer is because the force is applied less directly because they're using tape and wrap in place. Okay, information about manipulation. Once again, manipulation is listed initially on page there, and I think that's why I covered it a little bit because it goes a little bit out of order. In my work, I'm on the 2011. It's listed on page 576. And slide kind of didn't just now catching up to that information. So I'm just going to backtrack a little bit. So manipulation is the use of force to return a fractured bone to normal alignment. Repair codes are often divided based on whether manipulation was or was not used. Once again, we have to look for the term with or without manipulation when we're coding for fracture repair. Manipulation is a reduction, is an attempt to maneuver the bone back into proper alignment by bending it, rotating, pulling, or guiding the bone. And that is used usually by the provider's hands. And if you've ever watched like an action movie and you see the person that dislocates their shoulder and someone will come behind them and yank or pull their arm or their shoulder back in place, that's kind of what you'll think about when you're thinking about manipulation. So there are separate codes that are provided for fracture repairs with or without manipulation. And the question that is posed, is manipulation always required for fracture repair? The answer is not always. So in a simple, like a green stick fracture, manipulation may not be needed because the bones are not misaligned. And that's also, as you see here, is a reduction. So sometimes they'll say open reduction. So what they do is they've exposed the bone through the skin. The provider has done some surgery and cut the person open, and he's seeing the fractured bone with his scoped eyes, and he's using his hands, and he's put bones back in place. And then we'll have closed reduction, where he's not opening the skin. He's just using his hands to maneuver the bone back into alignment through the skin. Other terms are described by a physician in terms of the direction of the fracture line. You have horizontal, vertical, oblique, spiral, and the direction and degree of angulation. which is the most distal fragment. So annulation is the term that is used for the most distal fragment. Distal means far or furthest away, and proximal means near or close. So that's why you always review your medical terminology. As you can see, you have some terms here that you need to memorize and understand in order to code these things properly. And so what you would do, like I always say, is to jot down some notes in your CPT manual in these sections as you're reading the description that you're coding and you're comparing it to the description in the book. Look for those specific terms or their synonyms. As we know that we have the word manipulation, and the synonym for that is reduction. So the things that you need to pay attention to. So if a fracture results in more than 2 fragments, it is comminuted. To dislocation. Dislocation can be found if you're using a 2011 on page 579. Dislocation is the displacement of a bone from its normal location in a joint, and the treatment of the dislocation injury is to return the bone to normal location, so anatomic alignment, by a variety of methods. For example, if a finger was dislocated and the bone did not protrude through the skin, the physician may administer a digital block and apply gentle traction until the finger realigns. A splint would then be applied to keep the finger immobile for about 3 weeks. And if the shoulder was dislocated, the physician might elevate the arm and rotate the humerus while applying pressure to the head of the humerus. So look at the figures that I have listed here. We have your vertebral dislocation, where one vertebrae is out of alignment with the rest of them. You also have your pelvic and your femoral dislocation listed here. So the question is posed, what is the difference between a fracture and a dislocation? With a fracture, the bone is broken. With a dislocation, the bone is displaced from normal joint position, but it is not broken. So it's basically moved out of place. So a lot of times in the areas where the bone and joint joins together, there could be a possibility of a dislocation. So your vertebrae are separate bone segments that in between each of them are small joints. And in your pelvic area, the part of your body that connects your femur, which is your big bone in your leg, to your pelvis, that area is a joint. Any area in your body that moves or has some type of movable action, it's in your face, the bottom portion of your jaw, your area or your throat is connected by your temporal mandibular joint. So the portion or your mandible that is connected to the maxilla, which is your top part, because mouth moves up, down, and opens and closes, that is a joint. And there are possibilities that people can have joint displacement even in their face. So just know that any area that there is a connecting body or connects your bones to your body in an easily movable fashion, because some joints cannot move as easily, it's considered a joint. And so the treatment will return the bone to normal joint dislocation. Subheading general, and this book kind of goes a little bit out of order from the CPT manual, because the first section in the CPT manual is general, but on page 581, it says here that the first subheading in the musculoskeletal subsection is general. The name implies the subheading includes miscellaneous procedures that are not specific to anatomic site, just like a basic incision with the first code 20005 used to report incision and drainage of soft tissue abscess. and then low, deep fascia, which is subfacial, which is underneath the skin. There are codes in the integumentary system incisions that are for skin only. So what makes this code different from those in the integumentary system, that the code 2005 is reported when the abscess is located within the deep tissue and possibly even down to the bone that underlies the area of the abscess. So when you see the term fascia, that means that it's so deep underneath the layers of skin that is almost past the muscles nearest the bone. So that would be the code that you would use. Anytime you see the word fascia or subfacial, with that's not face, like your face that I'm talking about, FSCA, you know that you're dealing with your musculoskeletal system, as the muscles and skeleton is coded together. So past the muscles underneath the skin would be your, nearest to your bone. So that's what makes this different from your integumentary, because your skin are the first three layers on top, and then underneath that you have your muscles, and then you have your bones. Okay. General subheading. Let me go on. We talked about incision and talked about the depth. So the difference between integumentary and musculoskeletal incision code would be the depth of the incision going to be made. Musculoskeletal used when underlying bone or muscle is involved. And so is wound exploration, penetrating wounds that goes past the three layers of skin, very deep into the body, will go into the musculoskeletal system because it has penetrated the muscles. And it is on wound location, for instance, by body site. It includes enlargement, debridement, removal, ligation, and repair of tissue and muscle. So all is included in the general subheading, wound exploration. Let me go back. And in CPT index, how would we find the proper term to locate, or the main term to code for the wound is this term right here, the word wound. And then we go on to the anatomic site from there. And you're going to be looking for a code, whether it's the muscles or the area of the body. You're going to go by anatomic site from there. These procedures describe surgical exploration to an already open wound. Codes are separate procedure codes. They coded and reported in the following circumstance. One, if this is the only procedure performed, because the more complicated procedure would be coded, and then a lot of times the wound exploration and debridement or debridement included with the main procedure or the complicated procedure. But if it's just a wound exploration that is an already existing and open wound, then this is how they can be reported alone. And two, totally unrelated to another procedure performed at the same session. Okay, so moving to biopsy. We know biopsies is taking a sample of bone or tissue or muscle and sending it to a lab. So they're making an excision, and they're cutting or snipping or using any other form of removal to take a sample and study it for further testing. So the term is located in excision subheading in the CPT manual. So we have incision, and we have wound exploration, and we have excision, which is a subheading under that. And the range is 20200 through 20251. It says for bone and muscle. So biopsies of muscles and bones are listed under excision under the general subheading. The body biopsy codes are further subdivided according to the type, for instance, muscle or bone, whether it's superficial or deep, and in some cases the method that is being used to take a sample. Another code says, do biopsies include the pathology workup that follows the procedure? The answer is no, because this is coded under pathology, and this would be coded by the pathologist, which is a separate provider, and his services are separate and different than the performing physician that is actually taking a sample. And so divided by, once again, type of biopsy, depth, and some by method. So on to biopsy. Can be percutaneous, needle, or excisional. Percutaneous is when a needle is inserted and it's drawn, the sample is drawn out that way. And they can be separately. And if a lesion is excised in biopsy, only the excision can be billed. So cannot bill for the biopsy if you provide that is only, or working for the provider that is only excising the lesion. These would be two separate services that are being rendered. For instance, if you go to the doctor and you give him a urine sample, he may charge for his portion of evaluating the urine sample, but once he sends that sample off to a lab to do further study, then the lab will code for the additional studies that they do on the urine sample. So those, once again, the sample will come from the provider. He will take it. He will code for that. And then whoever performs the actual biopsy or review of the sample or tissue will code separately. And that, once again, the pathologist. The question that posed, what is the key difference between percutaneous and excisional biopsies? Percutaneous is can open, and excisional can be closed. How each type is performed, and it describes how coding may reflect several components of the procedure. So, those are, with a percutaneous biopsy, the surgeon may require use of ultrasound guidance with or without a radiologist, and if the biopsy is sufficiently complicated. Taken on one day, and based on the results, an excision was performed, the modifier 58 is appropriate on the excision code. And so it's a little different because some of the services are independent of another. So if you have some difference, or the provider is taking something from right arm that is just an extend, removing, and if he's taking something from the left arm that he's going to have biopsied, then he'll have to code those separately and use modifiers. Modifier 58 is staged or related procedure by the same physician during the postoperative period, and so he's going to follow up on a different day during the time that he's already done a service or procedure. The next service that he would bill would have to use the modifier 58 to denote that it is staged. He has a continuation of services that's going to be performed in stages on the same patient during the same 90-day global period. So your ways that you communicate to the insurance company what your plans are. You communicate to the insurance company, proper method of coding and using your modifiers so that you may be paid. Otherwise, there'll be a denial because a lot of surgeries require, a postoperative period, sometimes between 10 days and 90 days. And so I'm running out of time, but I'm going to talk a little bit here about the introduction or removal. So For general subheadings, codes are for injections and aspirations. So the synonym for introduction could also be an injection or an aspiration. Some an aspiration can also be known as a synthesis, when there's an insertion of a needle to withdraw fluid. It's an arthrocentesis, an amniocentesis, or just an aspiration. So what you would do in the heading or the subheading for introduction or removal, you would put in parentheses the terms or alternate terms here, injection, aspiration, sometimes synthesis. The introduction removal category includes codes for a wide variety of injections, aspirations, insertions, applications, removals, and adjustments. And so these codes are found in the musculoskeletal system, and musculoskeletal section of the CPT manual. So for in terms, sinus describes a fistula that leads away from a pus-filled cavity, as well as an air-filled cavities in the bodies of the skull. So the sinus tract injection procedure codes are used in an abscess or a cyst through injection of an antibiotic or other substance into the infected sinus by way of the sinus tract. And so the use of radiologic guidance would be coded separately, and in your CPT manual, you're going to see some small notes, maybe parentheses, that tells you that you're going to be using, separately, or for radiologic supervision and interpretation, use code 76080. So what you would pay attention to your description, find your proper code, and then always pay attention to the notes underneath. If description that you are trying to code says with radiological guidance or radiological guidance was used, or this type of X-ray or ultrasound, whatever was done or used with this procedure, we know automatically that we're going to have two codes. I'm completely out of time, and if you guys have any more questions that I've talked about today, please do not hesitate to give me a call or email me. I have about 2 more minutes, and so what I'm going to do before I end is just talk about grafts or implants, because they're similar to skin grafts, and that's probably something that you're going to cross, except, these are bone grafts. And I'll talk about that, and I'm going to go ahead and end for today. So let me go back to my proper page that I was in the step-by-step. One. And this. Okay, so with this word or this term, fascia lata grafts. It's from mid-upper thigh, where fascia is the thickest. Remember, fascia is the skin, the tissue that is closest to the bone, nearest the muscle, and that's fibrous connective tissue. It may be shaved off with a stripper or cut away. Codes for fascia lata grafts differentiate the method by which the graft material was obtained. So codes bundle together procedures and others do not. And the question is posed, how should a graft procedure be coded? So when the codes are bundled in obtaining and implanting the graft material. Obtaining means getting the material from a donor spot, implanting it to a recipient spot. If they're bundled together in your description that says includes hardening and representation in code, then you do not code anything separately. But some codes do include this information. If it is not included, then we would code separately. What's composite graft involve a combination of autogenous material and allograft or alloplast. And autogenous material, of course, comes from the actual donor itself. For instance, I can donate from one area of my body over to the area. For instance, one eye will give to the other thigh, one arm will give to the other arm, and so forth and so on. And so what you would pay attention to when you're dealing with grafts or implants is whether or not, your code is bundled and whether or not your code includes the harvesting, and also if it can be coded and billed separately. I'm trying to find the information in the chapter so we can see examples. Before I move. And then throughout the book, you make sure you do the exercises and check your answers in the back of the book, because you always want to make sure you have a good understanding. Okay. So it says page 587 that the code 900 through 20938 report the harvesting of bone, cartilage, fasciculata, tendon, or tissue through an incision separate from that used to implant the graft. Graft material is used in a wide variety of repair procedures. For example, if a tibial fracture has failed to heal in 20 weeks, the surgeon may decide that the fracture requires bone grafting to achieve healing. Bone grafting is also used in cases of large defects greater than 6 centimeters. Types of fractures commonly heal with difficulty. So, debridement, the surgeon may decide to allow a 5 to 7 day healing period before the bone grafting procedure is performed. Moving a little bit, fasciated grafts are taken from the mid-upper thigh area because fascia is the thickest in this area. Fascia is the fibrous tissue that serves as connective tissue. It may be shaved with an instrument or it may be incised, which is cut away. So codes for obtaining the fasciated graft are based on whether the stripper 20920 was used to remove the fascia or whether a more complex removal procedure, which is 20922, was required to obtain graft material. So those separate codes apart from graft itself, so you can code for the harvesting based on what was used and whether or not it was complicated. And then some information about tissue grafts. It says include obtaining of the fat, dermis, peritoneum, which is loose connective tissue from the tendon compartment, and other tissue types. So this is a tissue graft includes in the code itself. All of these things may be described in the harvesting of tissue graft or removing it, but they're not coded separately. And so what you have to pay attention to is the rule, all included. Okay, moving on. Some more information is under other procedures. For instance, you move down on page 588 to free osteotomy flaps, and this is talking about some additional other procedures. And the code ranges are bone grafts that include the skin and tissue that overlie the bone. The flap has an arterial pedicle attached, and there's a anastomose to or the recipient site. The surgeon then utilizes the skin, tissue, and bone to reconstruct a defect using a microscope. So what the pre-cutaneous flaps, and I didn't say that properly the first time, is that they cut off free donor bone and tissue or subcutaneous tissue that's like a flap. They free it from the donor site and leave all of the nerves intact, and they transfer it over to the recipient site, and they reconnect the skin, the tissue, and the arteries that the nerves and the nerve endings so that they can attach and work, actually along on the person's body. So I wanted to, I'm going to cover that. Oh, here it is. And those here, it says free osteocutaneous flaps, which is also known as bone grafts. And it says take in tissue in the overlying bone. So they basically pull everything up that's connected for that. And, of course, the blood vessels, that's in place, and then they, reattach the blood vessels to the new spot. And so the question is going to be asked, I believe, in one of your assignments that you're going to be submitting probably this week. So that's something that you would pay attention to right here, and the terms that are included in the integumentary system for the type tissues that can be used for a recipient, donor recipient, harvesting, that the terms that are in the system is also transferable over to the musculoskeletal section. So you have the autologous, you have the grafts, and you have a few other terms that you're going to be running across as well when you're dealing with grafting. So if you get a little confused, just flip back and forth, and one section, they correlate to another because this is all tissue. There are different types of tissue, but they're all tissue. Bones are tissue, muscles are tissue, skin is tissue, and so forth and so on. So if you have any questions, once again, don't hesitate to give me a call or email me. Thank you for watching. You guys have a great week.